talking about CFM, this is another very complicated presentation, rare presentation, but once it is there, it is quite difficult to diagnose and difficult to manage because we don't see so many cases. And for beginner, people who don't have very long experience, they might be quite puzzled by the presentation. Now, CFM is a misnomer, as we all know. It's primarily a neuropathy and not a myopathy. The problem is with the nerve that they have not developed and gone on to the target organ, that is the extraocular muscle. So there is, it's a neurologic problem, not a myopathy. Neuropathy affecting all are part of the cranial nerve 3, nucleus, nerve, and its innervated muscles, and not cochlear nerve and its innervated muscles. Fibrosis is variable and secondary event. It is not the primary event. So it may be a lot of difference from one patient to the other. So that will change the picture, clinical picture in different ways in everyone. And it's a rare presentation, 1 in 1.23 lakhs, 1.13 lakhs or so. So it's a very rare presentation. So you don't see many patients. Now, as we said, these are CCDDs. There is aberrant signaling of the extraocular muscles by neurons in the CNS. There are basically two mechanisms. One is the correct axonal targeting of the extraocular muscle, that is by KIF21A. This is kinesin, which transports cargo where the nerves are developing. So if there is a problem, this is not going to happen and the innervation is not going to be through. The other is motor neuron development, which are things like PHOX2A, which is TUB3 and TUB2B. So these are basically, they affect the CNS development. So there is a more generalized and more systemic problem. When you have problem with the TUB3 and TUB2B particularly, lot of aberrant innervation can be seen in these cases. We will be coming to that. Now tubulins these are proteins which are very important for neurogenesis, for neural migration, neural differentiation, and crucial for CNS development. These are basically microtubules which have these tubular proteins, and these microtubules are composed of the tubulin proteins. And TUB3, TUB2B fall in this beta tubulin category, and these, as I said, these are very important. If there is a problem with these, then the CNS development is going to be affected. So a lot of problems will arise in the CNS, systemic, and at the level of extraocular muscles. Now, as I said, in these CFMs which are involving TUB3 and TUB2B, you will have malformations of the cortical development, dysgenesis of the corpus callosum, absence of several peduncles, microcephaly, microgyria, polymicrogyria, vocal cord paralysis, and intellectual disability. So a lot of things can happen. We have to look at the systemic issues also in these cases. There could be systemic associations like facial paralysis, cognitive behavior, Kalman syndrome, sensory motor axonal polyneuropathy, bilateral inguinal hernias, and crypto-occultism. So we need to examine these patients systemically also. A lot of findings could be there along with. And you can have ocular associations like high refractive errors, astigmatism, amblyopia, optic nerve hypoplasia, typical colobomas, synesthetic divergence, convergence, and Marcus-Gunn phenomena. This is also likely to be seen with TUB3 and TUB2 variants more often. It can be seen with KIF21A also, but more commonly seen with TUB3 and TUB2 variants. There could also be hypoplasia of the sixth nerve in these cases. Now, there are at least 8 genotypes in CFMs. With KIF21A, we have CFM1A and CFM3B. With PHOX2A, we have CFM2. TUB3 has CFM1B and CFM3A. TUB2B has CFM3A, CFM3 with polymicrogyria, which is a CNS abnormality. And Tuchel syndrome, we don't know the responsible gene as yet. Most are autosomal dominant with 100% penetrance and expressivity. And autosomal recessive are CFM2 and Tuchel syndrome. So these two conditions are recessive. You can also have sporadic involvement, which arise from de novo mutation, but they are rare. I'll be showing 1 or 2 cases. Now, phenotypes have great variability in their presentation. They are often high refractive errors and high astigmatism. So always remember that you could be dealing with a lot of astigmatism, which could be causing a lot of amblyopia, and that needs to be tackled. Restriction of upgaze is sine qua non. All of them, most of them will have some limitation. Even if the eye is in the primary position, there will be difficulty in elevating the eye in upgaze. That is because of the IR fibrosis, which is very fundamental problem here. Usually they have a chin up position and ptosis. Ptosis is there in a good number of cases, but some cases may not have ptosis also. That's possible, they don't have ptosis. there could be an exotropia, esotropia, variable limitation of horizontal gaze. Now, more often you find an exo deviation in these cases, but you can also have an ESO in some cases, and limitation could vary from one shift to others. The two children, both affected, may have different horizontal gaze, but vertical movements are going to be affected similarly. So horizontal gaze is very variable. They may have a horizontal deviation or they may not have a horizontal. Some may have even no deviation in horizontal gaze, but as it goes up, there is a lot of problem. There is poor or absent binocularity in these cases. Now this is showing one family. You can see 3 generations. They are all 2 daughters, the mother and the grandfather. They have very mirror image presentation that shows how penetrant and how expressivity is 100% autosomal dominant presentation, and all look alike. Now when you look at the motility, you find there are some differences, of course. Like this girl, you can see she is able to move her eyes. There is a limitation of vertical gaze, but horizontally she can move both eyes, but there is in the left eye is moving less as compared to the, it looks like a left gaze palsy in this situation. Eyes are not moving left ways, and right side they are moving. So this is one presentation with an exo deviation, and you can see a lot of high astigmatism here of about minus 4.5. This is showing extorsion in this patient, maybe it's arising because of tight inferior rectus muscles. And this is showing the other girl. Again, you see high astigmatism about -7. And here again you have an exo, but the left eye is not moving so well and right eye is moving all right. So the limitation of movement in the left eye as compared to horizontal movement I am talking, vertically of course there is a limitation, and these can go into an ESO position in up gaze, what we call as A pattern. So that is also quite characteristic of these patients, that they will have an A pattern, but that is again seen more with TUB 3 and TUB 2 variants and less with KIF21A. This one had intorsion, maybe the superior oblique was also involved in this case. This is the mother, almost frozen eyes, and she has had cataract in both the eyes operated. At the time of first surgery, nobody realized that this is a CFUM. It was done in Guru Nanak Eye Center only, and diagnosis was missed. This is showing another family. You can see the mother and 2 children. This is a typical head posture in the boy, elder boy you can see, chin up position. And father is not affected, and both children and mother are affected. Here child has no horizontal deviation in this one. It has only vertical problem. There is no horizontal deviation here. This is showing a sporadic case. Again, he had a cataract trauma in left eye, and it's a sensory deviation here, large ESO. This is showing CFM2. You can see that there is, globes are almost fixed to the lateral canthi, and there is very little movement. It's very autosomal recessive and mostly described in Saudi Arabia in consanguineous families. This is something like CFM3. You can see unilateral ptosis. There is typical coloboma, and there is in the other eye there is anophthalmos with cystic eyeball. There is cryptorchidism and renal agenesis. So this patient had a lot of systemic associations. Of course, we could not do genetic analysis, but the features are very suggestive of unilateral CFM, which had systemic involvement. Some of these MEDs are also with IR fibrosis. They are also like CFM3 with TUB 3 variants. Some cases which have IR fibrosis, they could be CFM3, and there have been some reports that this MED is a unilateral CFM. This may be associated with MGP, facial palsy, and cortical malformations. These associations have been shown. There could be hypoplastic oculomotor nerve in these cases, and variable fibrosis of the IR. And association with TUB 3 pathogenic variants has been shown in some reports. So when we are looking at MED, we should also think of unilateral CFM, which could be there in these cases which are having tight IR. Now, workup would include relevant history, family history, systemic history, the CNS involvement, as we said, that particularly with TUB 3 and TUB 2 variants. Facial palsy could be there, cognitive, behavioral impairment, syndromic involvement, and joint contractures. All this systemically needs to be looked into. Visual acuity, amblyopia, we have to see refractive errors because they have high astigmatism. So we need to look at that, and abnormal head posture, which is quite often very classical. Ptosis, LPS function, Bell's phenomena, and corneal exposure are important to keep in mind because they have poor Bell's because it's very tight IR, so they don't even blink that often, and they are prone for corneal exposure. Then, of course, we have to evaluate the stenosis and the ocular motility, and misinnervation, which could be MGP and synergistic divergence. And we have already said that there could be this Marcus-Gunn phenomena. All this can be there in these cases. Now, MRI brain and orbits has to be done if you are going to operate particularly, or if you are suspecting CNS involvement, then MRI brain and orbits has to be done to document CNS involvement or CN 3, 4, or 6 involvement. And you could also have abnormalities of extraocular muscles insertions and thickness. You need to have photographic documentation, because whatever you do, you want to see how useful it has been. Then you have to do FDT and fourth generation test, and genetic analysis has to be done in these cases, which is not easily available with us. Now, differential diagnosis will basically mean CPEO, which needs to be distinguished. There could be bilateral congenital third nerve palsy, which is very rare, and you don't see many cases. There could be congenital Browns, which is bilateral, you may see. Mobius at times may create issues. And congenital MAD, which is a unilateral CFM, as I said, it could be mixed up. Now, CPO could be either Kearns-Sayre syndrome or Pearson or Mendelian PEOs. All these are variants which can present in different ways, and they may run into each other. So, Pearson has other findings also, systemic findings like anemia and diabetes, but it may also present with ophthalmoplegia. Now, as I said, we can have overlapping presentations with CFM, like you may have a Duane's, you have synergistic divergence, Marcus-Gunn phenomena, infantile deviations, Mobius, Kalman syndrome, and hereditary congenital facial paralysis or Newman syndrome. Now, treatment is non-surgical treatment would mean correction of refractive errors with glasses or contact lenses. This is very important, because if you don't correct, they will go for amblyopia. So, young children need to be treated for astigmatism. Glasses have to be prescribed, amblyopia has to be treated, and ocular surface lubricants have to be given to these children, because they are prone for dry eyes. Now, surgical treatment, you should be clear about the indications, as I said, otherwise you may end up in worse situations. So, to improve AHP, to align the eyes in primary position, to improve motility, to improve ambulation and gross motor development, and not all need to be put under the knife. So, all don't have to be treated. You have to be clear about what you want to treat, otherwise it may not produce good results. Now, the surgical approach is that you may have abnormal extraocular muscle insertions. So, MRI has to be done before you are operating these cases. You should know some idea about where EOMs are inserted. IR weakenings are maybe enhanced by SO weakening also if there is a need. Dissemination causing ET in upgaze may mask and XT that may surface after IR resections. Resections and plications can rarely be done if you do large resections, and some resections can also be done in some cases. And in residual situations, you can also inject botulinum toxin. Ptosis may need to be under-corrected, as Dr. Pradeep was saying in third nerve palsy also, because they are more prone for exposure. The challenges are surgery is difficult due to extreme fibrosity of the extraocular muscles, abnormal insertions. Resections need to be much larger than conventional. Their orbital bands and septi could be there. There is poor bells. So, ptosis surgery may lead to exposure, so we need to under-correct. Results are modest, multiple procedures may be required. So, one has to be told beforehand the patient that you may need more than one surgery. To conclude, it's rare presentation, prone for misdiagnosis, congenital restrictive ophthalmoplegia with vertical gaze, could be unilateral, bilateral, with or without ptosis, modest surgical outcomes. Think of CFM, CCDD in your practice if you are having a difficult presentation which doesn't fit into anything very typical. Just an invitation, we are having our midterm conference at Nagpur on 19th of this month. So, I request all of you to come and attend Nagpur event midterm conference.